So Simon has asked me to talk about the anatomy and radiology of skull-base pathology, and as I've only got 25 minutes, and there's quite a lot to get through. I thought actually I'd concentrate on one structure, and only just one structure, and that structure is very much the reason why we have skull-base surgeons. Let me see. There we go. So that's the facial nerve. The facial nerve is probably the most important structure within the temporal bone, and there's a reason for that. Skull-base pathology is unilateral, it's not bilateral, and therefore it affects just the one cochlea. So you always have hearing in the other side, on the other side. So patients aren't too worried about the potential for hearing loss. What they are particularly worried about is facial palsy. And that's more because of you have normal facial function on the contralateral side. And that makes facial palsy that much worse. And indeed, lots of patients will try and reduce their facial movement on the contralateral side to make their facial disfigurement less apparent. So patients will often present with present with a facial palsy, or when we discuss management of their disease, then it's the main thing that we talk to them about and try to prevent. And its anatomy is quite complex, not least for its relationship to the otic capsule. So what I'm going to do is talk about its course through the temporal bone, a little bit on the histology, blood supply, but also the associated pathology, because it brings in really all skull-base pathology because it's so important. We're also going to talk a little bit about surgical anatomy. At the end, I've got 4 videos that I hope will help you understand the anatomy of the skull base. So the facial nerve has a complex course through the temporal bone, and it leaves from the pons, it travels across the cerebellopontine angle, as the pontine part of the facial nerve, and then it enters the internal auditory meatus. And at this point here, as it travels across along the internal auditory meatus, it turns anteriorly towards the geniculate ganglion, and this is the first genu. And then it takes an abrupt turn posteriorly and comes across the medial wall of the middle ear cleft. And then it takes a shallow curve, which is the second genu, and down the mastoid vertical segment, which actually isn't that vertical. It actually runs away from you. When you're operating and performing a cortical mastoidectomy, it doesn't go across, it goes forward as well as it exits the stylomastoid foramen. And if we look at radiology, what we tend to find is that MR imaging is useful for pathology medial to the geniculate ganglion, and CT imaging is beneficial lateral to the geniculate ganglion. And that's because CT is good for looking at bony destruction. Of course, the facial nerve, if it is involved, will demonstrate that within the temporal bone. But more medial, of course, you've got disease around the brain and brainstem, and MR imaging is best for that. So the course takes us from the pons across the cerebellopontine angle to the lateral porus, and then the fundus of the internal auditory meatus. And here you can see it's like a train track. You've got the facial nerve and the superior vestibular nerve, and they run along in parallel, and you can identify that on scans if you look at a later stage. And then the nerve runs forward in the labyrinthine portion of the fallopian canal, and this is a tight canal. It is at its narrowest at this point, and this is why patients present with facial palsy, with Bell's palsy, because the viral edema causes constriction at that point and reduces blood supply. And then, of course, it cuts forward from the first genu and it runs towards the over the middle ear cleft. And this is best shown here with this lovely picture of the contents of the middle ear cleft. So the facial nerve is like a bridge, and it seems to be holding up the lateral semicircular canal. The lateral semicircular canal is above it, and at each end of its expanse, you've got the processus cochleariformis, which has the tendon of the tensor tympani attaching to the malleus. And we've got the pyramid here, which of course has the stapedius coming out of it. So it's crossing above the tensor tympani and the stapedius and the oval window. And this is a micro CT of the fallopian canal. As in the vertical portion, it comes down. You can see the posterior canaliculus where the chorda tympani comes across and out into the middle ear cleft, and there's the eardrum. So you can see it's a vertical here, but this is just in the a certain plane. It does actually run forward, which is important when you're dissecting it out. So this is my only slide on histology, be pleased to hear. The facial nerve, as it crosses the cerebellopontine angle and the internal auditory meatus, does not have an epineurium. And when you're operating in this area and you come onto the facial nerve, it's like operating on wet tissue paper. It's very, very delicate. And although relatively robust to compression, if you were to, it's very easy to evolve some damage. But it picks up its epineurium as the dural leaves come along and into the fallopian canal. And the epineurium is then coating the facial nerve. There is a little bit more of a cuff of periosteum around the stylomastoid frame, which is quite often quite difficult to dissect free, and then it of course extends into the parotid. The facial nerve blood supply is extremely important, and the reason for that is that there's a series of end arteries, and if each one of these supplies a portion of the facial nerve. So here is the branch of the posterior auricular artery, the stylomastoid branch, coming up and supplying the vertical portion. And we've got a branch of the ica that comes in and supplies the meatal portion. But it is the petrosal artery that is key in skull-based pathology, because if one loses the petrosal artery for various reasons, then facial function is compromised, because the stylomastoid branch of the postauricular artery and the branch of the ica cannot supply this area. And so if petrosal artery is lost, then patients will often present with a sudden facial weakness. So this is some scans and pathology. I won't go into these in too much detail because actually we'll be talking about them later. But here is a vestibular schwannoma. And as I was saying, as a vestibular schwannoma grows, there is compression of the facial nerve as it swings around the front of the vestibular schwannoma. And the vestibular schwannoma can cause up to, indeed, over 90% loss of neural function, but you don't get a facial weakness because of its ability to collaterally sprout and reinnervate denervated muscle fibers. And indeed, that's the same for the cochlea. And we know that with the cochlear nerve because patients who lose cochlear function and hearing can actually, because of tumor compression from the vestibular schwannoma, can actually have a cochlear implant and get good hearing back. So it is not the tumor itself causing compression of the cochlear nerve that causes hearing loss. It's indeed its effect on the cochlea itself, causing a cochlear loss rather than a sensory neural loss. Here is a small facial neuroma, and one can tell it's a facial neuroma rather than acoustic neuroma because it's got a hyperintensity here on contrast-enhanced MR imaging, but you've also got enhancement of the labyrinthine portion, and then it splurges out into the middle fossa where the geniculate ganglion is. So you've got this bilobe tumor involving the geniculate ganglion and also extending down into the internal auditory meatus at this point. I talked about blood supply. So the geniculate ganglion gives off, of course, the greater superficial petrosal nerve, but also the petrosal artery comes in. And here you have a cholesteatoma that's wrapping over the geniculate ganglion, involving it here, but it's also knocking off the petrosal artery, and this patient presented with a facial weakness because of that. The blood supply, as I was saying, is more important than compression itself. And here we have more laterally, involving the vertical portion, is squamous cancer of the temporal bone. And patients will either present with a painful bloody discharging ear and a facial palsy, or maybe not. And its involvement in the facial nerve, with the facial nerve, dictates whether we would tackle squamous cancer by performing a lateral temporal bone resection or a total temporal bone resection to get the disease out. And it's pretty much the main decision is whether the facial nerve is involved at this point. So I'm going to show you 4 videos now that identify surgical anatomy for you. And the facial nerve, as I mentioned, becomes involved with disease, as is the first case that I'm going to show you. And or it can be blocking our access to deeper disease, and therefore we have to move it around to gain access more medially. And so I'm going to show you these videos, but also the associated anatomy as one will be operating as the skull-based surgeon, going deeper and deeper into the temporal bone. So this is a case of a cholesteatoma that is causing a labyrinthine fistula, as you can see here, this white arrow. The facial nerve is in the middle ear cleft here. You can't see it very well on the CT, but the facial nerve is here. The facial nerve, its labyrinthine portion, is coming across. So you can see how complex this area is. You've got the facial nerve here, which is the tympanic portion. You've got the labyrinthine portion, which is about to go off anteriorly, and the wrapping is around the vestibule and the semicircular canals. So I'm going to play this video, which off we go. So this is the fistula here that I'm fiddling around with. The patient's got a dead ear. I know that. The patient had a dead ear for about 2 years. And the fistula is here. This is a cortical mastoidectomy. There's the bone of the posterior canal wall. We've got a posterior tympanotomy that I'm now looking through to try and remove disease from the middle ear cleft. And I just want to, I mean, to be honest, I'm just fiddling around here trying to work out what I'm going to do, which is often the case with skull-based surgeons. You really don't know until you get into the operation. But I'm trying to work out how I'm going to tackle this disease and get it out. Now, I've suddenly realized that the patient's got a dead ear. You'd have thought I'd have known that. So I've decided I'm going to take down the posterior canal wall because I'm going to perform a blind sac closure. There's no need for this patient to have an ear canal or an eardrum. So I'm going to take down the posterior canal wall, and it'll give me greater access to the facial nerve and the structures around the facial nerve. So now we've got more of a radical mastoidectomy. Facial neuromonitoring is so important during this type of surgery. So I'm just checking the facial nerve is working. And then I'm going to perform a labyrinthectomy or a partial labyrinthectomy. I won't go through this in too much detail, but what I'm trying to do is I'm trying to work out whether there is cholesteatoma extending down into the inner ear of the otic capsule and how far it's going down. So I'm going to perform, there you go, a labyrinthectomy or partial labyrinthectomy. That's the lateral semicircular canal. We've got the posterior canal down here, and this is the vestibule. And you can see me moving that cholesteatoma is causing movement in the facial recess. I'm going to just, there you go, there's a bit of cholesteatoma that comes out. Now, the reason why I'm showing you this video is because you can see where the facial nerve runs and its relationship to important structures. So here's the stapes footplate that I'm just about to take out now to make sure that I've got all the cholesteatoma out. So there's the stapes in close proximity to the facial nerve, looking now down into the vestibule. And we're going to just tidy up, take a little bit more of remnants of the cholesteatoma away. but you've got here the cochlea, the vestibule, the geniculate ganglion up here, and there's the bridge. So that's a facial nerve bridge with the vestibule behind, the cochlea in front, and the second genu here. So the next case is a little bit deeper. So this is a large vestibular schwannoma, medially placed vestibular schwannoma. There's not much disease in the internal auditory meatus. And we going to have difficulty in getting this area of vestibular schwannoma. So this is, we've done a blind sac closure again. So we're now looking down the ear canal. So this is the ear canal. I'm drilling out the ear canal, and the facial nerve is going to be in this area here. So I'm drilling down onto the facial nerve and creating from the stylomastoid foramen here, the vertical portion, which actually I said goes slightly anterior. And I'm just working around performing a labyrinthectomy. And now I'm going to just take off the bone around the stylomastoid foramen so I can then roll the facial nerve forward. So stylomastoid foramen, first genu there, second genu, and this allows access here to the cochlea, which is quite difficult to access if you don't move the facial nerve. You can do it. And there's the cochlea itself. So I'm now drilling out the cochlea to give me much more access forward. So I can go as forward as the carotid, because the carotid is in front of the cochlea. And here is the internal auditory meatus, the lower portion of the internal meatus. The facial nerve is going to run up, cut forward to the first genu, and then back around the second genu. So this gives me access now anterior to the internal auditory meatus by a transcochlear approach. The third video I'm going to show you, this is a chordoma involving the right temporal bone, central skull base. This is quite a few years ago, and one would approach this in two ways. It's quite difficult because the carotid is in the way, but we're going to access this from the lateral approach. But in order to get to this disease, one has to use a different technique, and this is a posterior hinge. So I'm going to show you the facial nerve in its entirety. So I'm just going to pause this here. So what we have is stylomastoid foramen running and the facial nerve along its vertical portion. As I say, it's like a bow. See, it's just curved nicely. So the second genu is here, but actually it's just part of a curve. And here is the geniculate ganglion. And what I've done is I've divided the greater superficial petrosal nerve and the petrosal artery, and I've kept the facial nerve in a bony fallopian canal. So I'm trying to prevent damage to the facial nerve. But what that allows me to do is to bring it back. And therefore, this is the anterior wall of the internal auditory meatus. We've got the carotid coming around here. The cochlea has been drilled out. So we can now get very much more forward to tackle disease that would otherwise be difficult if this facial nerve was in the correct position as shown there. So, that's a little bit deeper. So lastly, I hope some of you don't mind sort of indulging me. This is I'm going to show you a video of the internal auditory meatus. This are two slices through the internal auditory meatus. Higher one, you've got the V shape of the superior vestibular nerve and the cochlear nerve going into the cochlea itself and the vestibule. A couple of slices higher, and you've got, so it's not shown quite so well here, but on the side, this tram line of the facial nerve and the superior vestibular nerve. And the reason why I'm going to show you this video is because it was made by my colleague, David Moffat, who unfortunately has passed away during this COVID period, not because of COVID, but unfortunately because of that, we've not been able to celebrate what he's been able to give to us as skull-based surgeons. And I'm just going to play his video because it's a fantastic video, not least of his surgical skills, but also what is the anatomy within the internal auditory meatus. So what we have here is, this is a translabyrinthine approach to the internal meatus. This is a superior gutter up here, and the inferior gutter where the jugular bulb will be down here. And what we have is the superior vestibular nerve and the facial nerve tucked behind it. And what David always did was do a beautiful dissection to identify what's called Bill's bar, which is just up here. And that allows you to see the bit of bone that comes down between the superior vestibular nerve and the facial nerve. So it's just going to reposition it. And this is the transverse crest, which separates the superior vestibular nerve, which is actually just moved down a bit now, and the inferior vestibular nerve. And David always liked to leave a beautiful dissection at the end of the procedure. And so he's now avulsing the superior vestibular nerve. He's going to divide the last few fibers with a Jake's scissors. And then he's going to move along to divide the inferior vestibular nerve, which is just there. So it's just cutting through the inferior vestibular nerve and rolling that medially. And then you can see the cochlea, which is going to divide. Now, we don't often divide the cochlea these days. We sort of tend to leave it in place because it gives a little bit more support during the latter dissection. But what you've got now is 3 nerves divided, and the superior and anterior is the last of the facial nerve, which you can see up here in this MR scan, shown nicely. And there is the facial nerve. He's just going to just take a little bit of vestibular schwannoma out before the video pauses. So I'm not sure about time. Oh, perfect. So I'm not a radiologist, so I don't have nicely coloured scans to show you, but hopefully that gives you an understanding roughly of what's going on within the temporal bone in relation to the facial nerve, which, as I mentioned, is probably the most important structure. And I'd just like to finish with this slide by saying thank you. So David Moffat was my colleague for 18 years. This was a picture of Bacco in 1999 with his past fellows and colleagues. David worked very closely with David Hardy, the neurosurgeon. They were sort of a dynamic duo, and they really developed skull-based surgery within the UK, along with Richard Ramsden and Mike Gleason, really. And David Bagley, who is a real dynamo, driving publications during that period. And David was one of the first people to have fellows that worked alongside him. And if you look at the fellows he has, the luminaries like Glenn Croxon, John Rutger, Marcus Atlas, Juan Kirsoni, Phil Chang, and we've got even Richard Irving tucked along the back there. And indeed, lots of the people that are going to be speaking today have been through and been fellows of David Moffat. And so I'd just like to finish there, Simon. Thank you.
Thank you very much, Patrick. That was fantastic. The videos are amazing. Really demonstrates the anatomy nicely. We had one question early on about whether or not ligation of the middle meningeal artery when you're doing middle fossa surgery results in facial palsy because the petrosal artery comes off the middle meningeal. Is there anything you can add about that?
Well, I mean, the short answer is no. But I suppose what the issue is around the its close proximity to and its involvement also with disease. So the facial nerve can take quite a lot of hammering, but certain things will just tip it over the edge, and we'll hear later on about necrotizing otitis externa and other things that can cause facial palsy. But no, not generally. Of course, it depends where you divide it as well, I suppose.
Yeah. Can I ask you, in idiopathic facial palsy, which is pretty common, most people recover. But do you think in the patients that don't recover that there's a place for decompressing the facial nerve in the labyrinthine portion or other portions? And similarly, if it's a recurrent idiopathic facial palsy, is there a place for decompression?
So in short, both yes, but the problem is, and I do give 1 or 2 lectures on facial nerve assessment and treatment. And the problem always is when one would make a decision when to decompress. So with Bell's palsy, you are waiting for recovery and you're expecting recovery. And that recovery might be quick, it might take some time. So when would you decompress? And I think a lot of the difficulty in driving a prompt decompressive service is that patients will often get to us as ENT surgeons quite late, often after they've had quite a long period of that facial weakness. And so one often doesn't get to them early enough to perform decompression and have meaningful benefit from it. The other thing is you're also waiting for late recovery, and that can take some months before it arrives. And lastly, they might have lost their facial function, but they haven't lost their cochlear function. And so there's always a risk when you do decompression of the labyrinthine portion, a cochlear loss as well. And so for that reason, decompression of the facial nerve is performed rarely around the world, although recurrent facial palsy does warrant decompression and certainly should be considered.